Doctor, how are you?
I'm good. How are you?
I'm fine. Let us first do the introduction to our people.
Yeah.
This is Samuel Sane from Kenya, representing teams in Kenya and also East Africa. And I'm here with my best doctor, my personal doctor here in India. He is Dr. Sreekanth Appassani, and I would like him to introduce himself and tell you who he is. Welcome, doctor.
Thank you. Hi everyone. I am Dr. Sreekanth Appassani, consultant interventional gastroenterologist in Hospital Secunderabad. I have done my graduation from Andhra Medical College, Visakhapatnam. It's a small city in India, and graduation from internal medicine at Hyderabad, and my specialty of gastroenterology from PGI Chandigarh. After that, I had my specialty training in endoscopic ultrasound, later in third space endoscopy, and I practice all advanced interventional procedures of gastroenterology.
Wow. Thank you, doctor. For how long have you been in this specialty?
Um, I have been practicing gastroenterology practically from 2000, somewhere around 7, 8. But after completing my formal training and advanced training, these advanced procedures I have been doing for the past decade, from 2013, 2014 on.
Wow. You have a lot of experience. So far, how many patients have you met and treated these issues, gastro issues?
Routine gastro issues, we see a lot of patients. The number is huge. We see at least 50 to 100 patients a day. And if you ask me, the total number will be more than a few crores of patients. Advanced procedures, however, will be limited. I would say they are probably around the thousands per month, around a few thousands per month. Thousands per month. These advanced procedures in endoscopic ultrasound, third space endoscopy, these advanced procedures, patients needing these advanced procedures are not that very high, but they'll be there around a couple of thousands.
Wow. What is endoscopy?
Okay. So I'll put it in a very simpler way. If suppose you have got fever, how do you know it? You put a thermometer in your mouth or in your axilla and then you say that, okay, the temperature recording is this much, so you have. If you have diabetes, you take a blood test and check the sugar and say that, okay, the value is more than this, so you have diabetes. So like that for gastroenterology, for diagnosing these gastric issues, we do an endoscopy. Now, what is meant by an endoscopy is a small pipe. It's a very small pipe of around 6 to 9 millimeters, less than a centimeter. Okay, that small pipe has got a camera attached to the tip. We pass it through the mouth into the food pipe and the stomach, and we diagnose problems inside, and then we treat it accordingly. If we do this test from the mouth, it is called as an upper endoscopy, and if we do it from below, from the motion passage area, the anal canal, we call it as a colonoscopy. In that, we will be noting down the upper intestine and the lower intestine, and we will be diagnosing the problems associated with them.
Wow, that is great. No, there is growth, cancer, and ulcer. Can it be detected using this instrument known as
Yes.
endoscopy?
Yes, obviously. So ulcers, small erosions, all are detected through the endoscopy. Growths, cancers, and polyps are also detected through the endoscopy. In fact, we actually recommend a screening colonoscopy that is done through the anal canal for every person who is above 55 years of age. So even if they don't have a complaint also, it is recommended that they undergo these screening colonoscopies. We call them screening colonoscopy once in every 8 to 10 years after the age of 55 years. It is immaterial whether you have a problem or not. You still need to get it done after 55. That is because we detect these early cancers in the form of small polyps before they spread out to different places. So polyps, cancers, ulcers, and other small gastro issues are also detected with the help of endoscopy and colonoscopy.
Wow. I have heard people talking about gastritis. What is gastritis?
So it's you can say it's a colloquial term for acidity, the upper intestine problems. So gastric means the stomach, which is the second part. After we eat food, the food enters the food pipe and then goes into the stomach. So any inflammation happening. Now, what is inflammation? Again, I'm not trying to use technical words for your understanding. Inflammation is a technical word. Somebody slaps us, our cheek becomes red, right? So that is what is known as inflammation.
Yes.
Reddishness, some swelling around the area. So if the stomach becomes reddish, it's swollen up, or some ulcers are there, that is what is known as gastritis. So this is a term which we use whenever somebody has got a discomfort in the upper abdomen and some problem around the stomach area. We call it as gastritis.
Wow. There is a difference between gastritis and chronic gastritis.
So chronic gastritis means this problem of that inflammation, that is swelling and redness of the tummy, that's the stomach, is lasting for more than 6 months. It generally happens with infections which is known as H. pylori, sometimes with problems of the intestinal lining. The lining becomes thin, the acidity becomes more. So these are the people who will suffer from this chronic gastritis.
Is it curable?
Yes, it is curable. If there is a H. pylori, which is a common infection which causes increased acidity and gastritis, if we treat that with the help of medications, the initial 2 weeks will be with some antibiotics, later on with the acid suppressing medications. If you take it for a couple of months, most of the time this acidity issue resolves. However, the most important thing here in all the treatment of acidity or gastritis related problems is diet and lifestyle. Now, diet and lifestyle.
Yes.
So it is just not the fact that I give medicines and the patient is cured. So the patient also has to maintain a good lifestyle. He has to eat on time, eat healthy foods, avoid junk foods, avoid masala, these spicy type of foods, avoid smoking and alcohol. If he or she maintains the diet and lifestyle, this gastritis problems can be controlled after using the medications, I mean to say. So just using the medications will not cure you of the problem. Medications will help in reducing the issues, but maintaining that saint nature of the stomach is with the diet and lifestyle modification.
Wow, it's good to know this, doctor. And most people like, especially in Africa, most people like alcohol and all these other smoke. Other like here in India, I found that you like spices so much and also pepper. Is pepper bad?
Spices and pepper, if you ask me per se, they are not bad for health, but anything in excess is going to cause a problem. So anything which is taken in small quantity is good for health. Now, you add lot of pepper, lot of spices to your food, that's going to cause the trouble. Small amount of spices, small amount of pepper is not going to cause any trouble.
There is also condition that affects so many people and don't know about it. Irritable bowel syndrome. Is this?
So irritable bowel syndrome is a word, IBS. They abbreviated in the form of IBS. It is there a problem of the large and the small intestine. So basically what the patient suffers typically is an altered bowels. He either passes too many bowels, too many motions, or he doesn't pass it on time and he has a pain or a cramp every time he passes or he doesn't pass the motion. So some discomfort and some disturbance of the bowel is what we call as an IBS. Now, this IBS, I generally don't call it as a disease. Why? Because disease is something which spoils your organs.
Yes.
I'll give you a better example and I'll come back to IBS. For example, malaria is a disease.
Yes.
Malaria is an parasite. It affects the body. It causes fever, and if left, it can affect the brain. It can affect the liver. So that's a disease, because if I don't treat malaria, the brain is going to fail, the liver is going to fail, the kidneys are going to fail, and we are going to suffer because of that. So that's a disease. Now another simple condition, appendicitis. We all know we get that pain and the surgeon operates and you are relieved of that pain. Appendicitis is a disease.
Yes.
Because if the appendicitis is not treated, it ruptures, it causes havoc and other main problems. That's a disease. Now we'll come back to this IBS. IBS is not a very big disease because it is not because of any intestine related major problems. It is the sensitivity of the gut is increased in these patients. So the patients perceive more amount of pain, but there is no disease inside the intestine.
Yes.
Suppose I don't treat an IBS patient, he's going to have some suffering, he's going to have some pain, he's going to have some motions this way and that way, but his intestine is not going to get damaged. His life is not threatened.
Yes.
So that's why I don't call it as a disease per se, because there is no major abnormality of the intestine.
Yes.
What happens is the intestine is a bit sensitive. It starts perceiving more. It reacts more to simple problems which are happening inside our intestine. So that's where the patient suffers from, in the form of either altered bowels or pain. So IBS is a problem where the patient has some bowel problem with some pain, passing more motions or less motions with some pain, passing mucus, etc. There is no major disease, there is more major disturbance of the intestine, and these are the people who will need supportive care along with medicines, so that they don't get troubled by this more often. Diet and lifestyle modification need to be done so that they can improve from this sensitive gut phenomenon which we call it as IBS.
Wow. There are special medicine for this?
Yeah, there are medicines, a simple medication, they're not special, but there are simple medications which will take care of the gut sensitivity. We give some probiotics and all to make sure that the gut homeostasis, is so gut homeostasis means the good bacteria, bad bacteria inside the intestine, they will not create any disturbance.
Yes.
So that we supplement these bacteria so that these good and bad bacteria have a good balance and the disturbances don't happen. So these are the routine medications which we give for other problems also, we give for IBS patients also, and we give some medication to suppress the sensitivity so that the nervous system doesn't overreact within the intestine and the patient's symptoms get alleviated. So these are routine medicines which we commonly use. They are not very special medications. We use it for a small period of time. We give them more diet and lifestyle modifications.
So, thank you, doctor. Now, there is a common one that you know very well, and I know you have encountered it from so many patients. Ulcers.
Yeah.
What is ulcer?
So ulcer means the surface lining of the intestine gets eroded. So this is again a technical word, so I'll make it simple for you. You fall down, you have a hurt, your skin gets peeled off.
Yes.
That is what is called as an ulcer. So the lining of the intestine, if it goes away, that's what is known as an ulcer. It can happen because of various reasons. Medicines, painkillers cause ulcers. H. pylori infection causes ulcers. Then having increased acid secreting medications inside, that causes ulcers. Some special medicines, if not taken properly, can cause ulcers. Multiple reasons are there, but these are the common ones.
I had some people sometimes back saying that when I'm stressed, I can get ulcers. Is it true?
Yes. Again, ulcers are not only caused by this food-related issues or medicines, it is also caused by diet and lifestyle. Now, why diet and lifestyle? Because in the lifestyle, if a person is stressed out, what happens is so many stress hormones are released, which will include steroids also. So they will increase your acidity, that is, they increase the acid output, and the steroids also cause some discomfort into your tummy by causing ulcers and erosions around the gastric epithelium. So stress and anxiety will cause some changes in your hormone levels, and that leads to increased acidity, ulcers, gastritis, etc.
Now I get the formula where the ulcers comes from. Now, which is the best way to treat ulcers?
Medicines. So what we generally give is acid reducing medication. We call them as proton pump inhibitors. Nowadays we have got a newer medication which we call as PCABs, that is vonoprazole, which also reduces the acidity. So these help in reducing the acid. So now what happens is, once the acid levels comes down, the body's healing power will automatically cover that area where that epithelium is gone away. It will heal that area and the ulcers completely get healed. So by giving this medication, the acid output reduces, the acidity levels come down, and then the ulcer healing starts. We also give medications for H. pylori, which is a bacteria which causes ulcer formation. In fact, the person who has detected the H. pylori was awarded Nobel Prize for this particular discovery.
Wow.
So we give bacterial reducing medication, that is antibiotics, along with acidity reducing medications, and once we eradicate this H. pylori, the ulcers automatically heal and they don't come back.
Oh. No, apart from ulcers, there is growth and cancer. Do you treat them?
Yes. Um, Growths and cancers. Growth is a colloquial word, cancer is a technical word. So anything which grows abnormally around a place is called as a growth, and that's the reason for these growths are cancers. So cancers can be treated if they are very early. That is, if they are only in the upper part of the wall of the intestine, our food pipe, everything has got four layers: mucosa, submucosa, muscle, and serosa. Now, if the cancers are in the first layer only, I can remove it through the endoscopy route. Okay, but if it has involved the second and third layer also, surgery needs to be done.
Okay.
So in the treatment of cancers, I get involved in the diagnosis. First, we do an endoscopy, take a biopsy, diagnose cancer.
Yes.
And if we find that they are very, very superficial in the upper part, first layer, I remove them endoscopically. If they have gone down, that is in the second and third layers, then the surgeon operates and removes the whole cancer.
Wow, it's good to know these things. Now, what is acid reflux?
Acid. So, again, it's a common acidity problem. Again, many patients will have some burning here in the chest. So that's because the acid, which is a normal part of our intestine, that is the stomach part of it. So the acid is a normal digestive. Now, if it comes back into the food pipe, that is known as acid reflux. So we start developing burning sensation in the chest. We can have difficulty in swallowing food. Sometimes sore eructations come in. Throat becomes a bit difficult. So these are the common complaints when acid comes back into the food pipe. And the common reasons for this is again diet and lifestyle, not eating on time, eating very late in the night, eating a very heavy meal, smoking, alcohol, all of these cause increased acid reflux.
Wow. Is it treatable in form of medicine or surgical?
So the basic treatment is in the form of medications only. Medicines, we start off with the same acidity reducing medication and some prokinetics to push the acid down and not allow it to come back. So these help in reducing the symptoms. But if the nature of this reflux is very high and it is causing damage to the food pipe, that is, it is causing damage to the food pipe, that is the esophagus, in the form of ulcers, strictures, and all, that's where we adopt other treatment modalities apart from medicine. Medicines will always be there, but in addition, if the medicines are not working or there are complications, there is problems in the food pipe because of this acid reflux, we ask them to go ahead with surgery. Fundoplication, that is, this food pipe is wrapped with the stomach, and then the sphincter pressure is augmented so that the acid doesn't come back. So that's the surgery which we commonly do. Now we have one more new modality which is known as GERD-X, which we do endoscopically. So the same surgery which is done, and by wrapping from outside with the help of laparoscope, I do it endoscopically and create the tight wrap with the help of an instrument which is known as GERD-X, with which we reduce the acid reflux and patients can be relieved of the symptoms, and maybe we can stop the medicines also if the relief is much better.
Wow. So we are heading to, because of technology, heading to a better way of treating acid reflux.
Acid reflux, many gastro problems we are having now endoscopic therapies also. With the advanced modalities, we are able to do the treatment for patients without a surgery. Of course, surgery will be needed in severe cases, but in mild cases and all, endoscopic therapy offers a very good role for the management.
Wow. Doctor, I came to know you because of a condition I really suffered for many years, for about 14 years, 15 years ago. You treated me achalasia cardi. So many people don't know about achalasia cardi. It's a very rare disease. I would like you to explain to my people what is achalasia cardi.
Yes, achalasia is not a common. I don't say it's very rare, but it's not so common as that of acidity, gastritis, acid reflux. Now, achalasia is a problem of the food pipe. The normal, before understanding achalasia, we should know what our normal food pipe does. When I swallow something, whether it is food, water, anything, the food pipe moves and pushes the food down. So when that movement happens, it has to happen in a very organized way. Okay. So it is something like you're walking towards a train or a bus or something. You need to maintain a queue system. Everybody goes in, nobody goes in. So everybody, if they go in a queue, then easily people can enter the bus. So like that, the movement of the intestines happen in an organized way. If this is the food pipe, you think one part contracts and the lower part of the intestine relaxes so that the food can come from here to here. Now, this part also should contract and the lower part should open up. Now the food moves from here to here. Now this part will contract and the lower part will open. Now the food will move from here to here. So this movement is called as peristalsis. So one part moving, one part relaxing, one part moving, one part relaxing. Now for this to happen, like our house electrical system, we have nerves within our intestine. So we have nerves in our brain. The same way there are nerves within the intestine wall. So these nerve system coordinate. They will say, like an orchestra, it will say this part contract, this part relax. Now this part contract, this part relax. So this nervous system gets damaged in achalasia. So what happens is the food pipe doesn't move. So the food doesn't go down. However, since we eat food in the sitting posture, we don't sleep and eat, right? So we eat in sitting posture. What happens is, if suppose I eat food with gravity, things will come down. So what will happen is, slowly this food by gravity nature, slowly, even though the food pipe is not pushing it down, it comes down to till this level. That's where the food pipe ends and the stomach part starts. Here there will be a sphincter which will prevent the acid reflux. So that sphincter will not allow the food to come. In a normal person, because of the nerves, it will know that the food has arrived and it will open the gate, the food goes in, the gates get closed. Now this gate mechanism is gone and it is always closed. After a few couple of hours, some amount of opening happens, this goes down and rest of the food stays back. But this sphincter doesn't allow the food to go down and the food gets stuck and the food comes back again through the nose, through the mouth, people keep vomiting. So this is what is known as achalasia, where the nervous system of the intestine, that is mainly the food pipe, is damaged. The food pipe doesn't move. Food gets stuck at the lower part of the esophagus, that is the food pipe, and food doesn't go down.
Wow. What causes the achalasia cardia?
We have various reasons. Virus infections are one of the most common ones. Some nerve degenerations happen, so the nervous system gets affected. But we don't say that this is the particular, we don't have one particular reason, but there are multiple viruses and bacteria which can cause destruction to this particular nervous system, amongst which Chagas disease is one thing which we know. Rest all viruses are not yet known also.
Okay. Which are the modes of treatment of achalasia cardia?
So achalasia was being treated for decades together with the help of balloon dilatation. What we used to do is the food pipe, the sphincter which I was talking about, which was not opening properly, we all used to do, in fact I also used to do the same thing, put a balloon from above and stretch it and make a tear in the food pipe, that is the esophagus muscle, so that the food pipe opens up and we used to allow the food to go inside. So that's known as a balloon dilatation. And in severe patients, we used to subject them for surgery. That is a laparoscopy or an open way. People used to go from outside, cut the food pipe muscle so that that tight sphincter which I was talking about here between the food pipe and stomach, that opens up and the food goes down. Now comes this beautiful modality which we call it as a POEM, per oral endoscopic myotomy. Now this is the same treatment which the surgeon used to do from outside, we are able to do through the intestine, through the endoscopy route. Now, in my previous discussion, I was talking about 4 layers of the wall. The first layer is the mucosa, second layer is the submucosa, third layer is the muscle, fourth layer is the serosa. So technically, let us leave. The third layer is important, that is the muscle. So here, what I was talking about is the muscle is tight and it is not opening. So I need to cut this muscle. So what I do is I create a small hole here inside the food pipe, go between the first and the third layers. That means I go like a small tunnel, go down till this food pipe lower end. When I encounter that muscle which is tight and closed, I cut that muscle there, and then I come back and clip that area with the help of endoscopy only, where I have entered. Now the advantage of this over surgery and other techniques is that the patient can start eating the very next day. You just have to keep the patient fasting for 1 day when we do the procedure. Second day, patient is on liquid diet automatically. So the recovery is much faster when compared to surgery or any other techniques. And the success rate, the most important part is the success rate is more than 90%. So majority of the patients with achalasia cardia improve a lot after this myotomy, which is per oral endoscopic myotomy or the POEM surgery.
Now, doctor, I'm a victim of achalasia. I received Hellas cardiomyotomy 2009, which it was not, I cannot say it was 100% successful. It was around 50%, I can say, because I had to seek further treatment here in India. Now, what is advantage of poem surgery over Hellas myotomy?
So, as I told you, this is a precision surgery because I'm able to see the muscle under endoscopic route, and the length of myotomy is very well controlled. So, over Heller's myotomy, if you ask me, the length of the muscle which I can cut is more clear, more precise, and we can determine this length based upon your symptoms. In Heller's myotomy, the length of myotomy is restricted. We can't do more than 4 to 6 centimeters of myotomy. Suppose if we need to do the muscle cutting more than 6 centimeters, sometimes we do 8, 10, 15 centimeters also. That is much more easier and feasible through the poem surgery route than the Heller's myotomy. And the second most important advantage which I feel, because I do poem surgery, that is poem endoscopic therapy, is that the patient can be relieved immediately. So we start feeding the very next day. So second day onward, the patient is on liquid diet. The recovery process is very fast because there is no surgery involved, and we don't keep the patient for more than 24 to 48 hours within the hospital. So the main advantages are the shortened hospital stay, lesser cost, lesser morbidity to the patient, and a very good equal success rate to that of surgery, or sometimes more also.
Wow. Doctor, the doctor who referred me here is a doctor practicing in US.
Okay.
He told me something. With Hellas myotomy, doctors only open the front side of the stomach,
Yes.
not the spinal cord side of the
Yes.
stomach. Is it true?
Yeah, Heller's myotomy is an anterior myotomy. They do from the anterior side, whereas in poem we can do either anterior or posterior. So we can do myotomy on the front part, on the behind part also. So in poem we have access to both. We do it based upon the patient's convenience and patient's past history. For example, somebody has undergone Heller's, then we do on the posterior side only. If the patient hasn't undergone any previous treatment, then we decide based upon the age and other conditions.
Wow. If you can advise someone who is suffering achalasia and maybe misadvised on different types of treatment, would you prefer to do poem or Hellas myotomy?
See, I would prefer to do a poem procedure because of the precision nature of the myotomy. I'll tell you my practice. If you ask me the same question in 2011, 2012, I would have told balloon dilatation will be a procedure, but the best treatment is Heller's myotomy. Because at that point of time, poem was not existent. In fact, I myself, I have referred so many patients for Heller's myotomy because balloon did not work, dilatation did not work. Now, talking about 2024, 10 years down the lane, after poem has evolved into such a nice procedure. If you ask me my first choice, if I have achalasia, I would prefer to undergo poem procedure because it is easier from the patient perspective, because 1 or 2 days of hospitalization only, faster recovery, lesser pain, lesser morbidity to the patient, and I would say equal or slightly better success rate when compared to surgery.
Wow. Thank you so much, doctor. There are various issues. I've had people talking. One of the doctors say that poem is not good for patients back in Kenya because once you're done, you have acid reflux. Is it true?
Acid reflux is a problem after poem because that's the protective mechanism which is there preventing reflux. But we have a special type of myotomy where we preserve some fibers. Those are very technical. I just mention them for mentioning sake. Sling fibers and clasp fibers. So we cut the clasp, we preserve the sling fiber. So in that phenomenon, we preserve this reflux mechanism, preventing fibers, and the reflux becomes less. Yes, when 2012, 2013, when Dr. Inouye started doing the poem way back in Japan, at that point of time, if you see, the reflux rate was high because the procedure was just evolving. Now it's much more ultra refined procedure. We do a selective myotomy. The chances of reflux right now are less than 1/3, that is less than 30%. In fact, if you ask me in my practice, reflux is less than 10%.
Wow.
So the reflux is there, I don't deny it, but the rates have significantly come down. They're less than 10%.
Doctor, we are progressing. There is something else I saw from the entrance of your office. You do bariatric surgery for weight loss management. What is this?
So weight loss predominantly happens if you eat less, right? So if somebody needs to lose weight, they have to eat less. So that the initial part starts with our own willpower. We start eating less. That's what we call it the dieting. But there is some limitation to it. After a period of time, you can't control yourself and you start eating. That's where these treatments come in. The size of the stomach is attempted to be reduced so that the amount of food you take will be automatically reduced. Because if the size of the stomach is shortened, it's reduced. If you eat more, you'll vomit. So in a normal person, with my willpower, I can reduce it to a certain extent. But if the willpower gets overwhelmed and you start eating more, you'll gain the weight. Now, in these bariatric procedures, you reduce the size of the stomach. So I do a special type of endoscopic bariatric maneuver, which we call as the endoscopic sleeve gastroplasty. So in that, what happens is the stomach is stitched from inside through the endoscopy route. So that comes from the concept that the stomach part is removed by the surgery, which we call as a sleeve gastrectomy, which is a surgery. Now, instead of cutting and removing this part of the stomach, we just suture it. So how do I do it? If you think this is my stomach wall, I just pull it up like this, pull it up like this, pull it up like this, like this. So automatically, see, I had to bend down because this is shortened.
Yes.
So it was this much initial. So that is what we call as a suturing. So we suture the stomach part by part and then we reduce the capacity of the stomach. And this is also a daycare procedure like POEM where the patient can be discharged on the very next day itself.
So no cutting the stomach?
No cutting the stomach. It's only just the endoscopic suturing and the stomach becomes automatically shortened.
Without trouble, without stress and painless?
Yes.
Wow. I didn't know. What about balloon? What is balloon?
Balloon is a temporary procedure where we put an inflatable balloon with some dye-based liquid inside the stomach that will physically obstruct the stomach and then reduce the capacity of the stomach. The advantage is that it will create the same effect like what I was talking about, but that's temporary. 6 months or 1 year is the maximum time the balloon can be inside. So once we remove the balloon, again the stomach will have the same capacity and there is a chance that patient might restart eating and then gaining the weight back. So balloon is a good procedure when the patient is determined for short term and then the patient, if he is maintaining with this willpower and all, then that's a good procedure. But ESG, endoscopic sleeve gastroplasty and further surgeries are good procedures because they will reduce the weight, the size of the stomach permanently. So the patient reduces the food intake and continues to lose weight.
Wow. There is this also. How about bypass? What is that?
So bypass is a surgery. So patients who have got a BMI more than 40, that means we call them as morbidly obese, super obese we can call. So those are the patients who have got weight more than 120, 130 kgs and all. So they have, it's just not the diet factor. Even if we reduce the size of the stomach and reduce their food intake, their weight loss is not going to be much. So we have to divert the food from the stomach. Instead of getting absorbed in the intestine, we want it to go to the lower part of the intestine so that the absorption doesn't happen, nutrition doesn't go into the body and the weight loss happens. So that's what we call as the biliopancreatic diversion, LPBD surgeries, which are a part of bariatric surgeries, which are heavy weight loss surgeries where the patient definitely loses a lot of weight. And these are good for patients who are having morbid obesity, that is weight of the range very high, that is BMI more than 40.
So you advise people to do the bariatric procedure?
See, it depends upon the patient's willingness, patient's comorbidities and patient's weight and BMI. If the patient has got a very high BMI, then they are good for bariatric surgery. They will benefit from bariatric surgery. If the patient has got a moderate one, that's the BMI between 30 to 40, and the patient is having a willpower to reduce the food intake, willing to do exercise also, then endoscopic therapies, either balloon or sleeve gastroplasty, would be helpful for the patients, because these patients can lose weight and can maintain with the help of diet and lifestyle modification.
We are proceeding. Okay. There is also the issue of kidney stones. Do you treat that?
No, kidney stones is treated by my colleagues who are called as urologists.
Also, you don't do liver?
Liver, I am a gastroenterologist and a hepatologist at my training level, but I have progressed myself into the advanced therapeutic endoscopy. So, liver, we do treat the liver patients basically, but transplant and further higher procedures like liver transplantation and other liver related issues are tackled by my hepatologist. There is a transplant hepatologist who takes care of that, who takes care of all these cirrhotic livers where transplant needs to be done.
Wow. Thank you, doctor. And I would like to appreciate your efforts to meet me, to have an interview with me, at least to help my people. And I wish to come next time and we share more and the things I don't know, because I'm at least enlightened, and also to enlighten my people in Africa. And also wish you to come over in Africa and say hi to my people. Also treat them such cases like arthritis and so many. I wish you to come, and we hope for the best. Thank you so much. He is Dr. Sreekanth Appassani at King's Hospital. And we thank you, Doctor. We appreciate it.
Thank you. Thank you for the invitation and for the warm
Thank you so much.
hospitality.
Have a good time.